first, we'll start off with Ms. Kristyn Hare's talk on the Fracture Liaison Service, incorporating bone health optimization into it. Glad to have Kristyn here. She's a physician assistant and clinical densitometrist with a special interest in bone health and treatment of osteoporosis. She's been doing this for quite some time and has been in the orthopedics world for over 15 years in various aspects of it, and has really been fundamental in setting up the FLS and BHO service lines at UW Health in Madison. So Kristyn, take it away.
First of all, I just wanted to welcome everyone to National Osteoporosis Day. IOF this year had some very nice patient information posters that we shared at our clinics with steps to better bone health. So it was a good day for that. Okay. So we'll just briefly discuss Fracture Liaison Service key points, bone health optimization key points, and then look at the commonalities between the approaches to transition. So when we talk about our FLS service, we're looking at identifying patients presenting with fragility fractures from a fall of standing height or less, for example. We provide education on the link between bone health and fractures. Then we look for secondary causes of osteoporosis and recommend and initiate treatment out of our clinic. And the goal with that is to prevent future fractures. When we talk about our bone health optimization approach, we're looking at optimizing bone health prior to elective surgery. So we're screening patients to determine whether a bone mineral density test is needed to start, and then providing counseling for nutritional supplements, eliminating toxins such as tobacco and alcohol, assessing falls risk, providing education for bone health. And then if they meet criteria for osteoporosis after this assessment, setting up a bone health evaluation to start treatment if needed. And the goal with that is to prevent surgery complications. And we set up our FLS with American Orthopedic Association Own the Bone, which is a really nice out-of-the-box solution, so you don't have to reinvent the wheel. So again, it just has the same key points, looking at that FLS being capturing patients after their fracture to prevent the next one during that teachable moment when it's fresh in their mind what that felt like and how it impacted their life. And then this program has some registry-based documentation of performance, and they have expanded their program recently to also include entry for patients for bone health optimization that have not yet had a fracture, which will be a powerful database to help move the field forward and get some data for us. And really, it's a very logical extension of the Own the Bone concept from the Fracture Liaison Service, whether it be physician experts, physician assistants, advanced practice nurses who are used to working as a team with their surgeons to optimize bone health, not just after fracture, but also prior to surgery. There's been some publications starting to show up on these topics over the last few years. So when we set up a bone health consult, whether it's fracture liaison or bone health optimization, we're doing a detailed medical history, physical exam, bone mineral density x-ray results, secondary cause lab workup that's pretty detailed. Lots of education to make sure we're hitting those key points with nutrition to feed the bone. And then we use a document that has been developed with American Orthopedic Association, just kind of summarizing those steps for patients to have as a take-home format as a reminder. And then we prescribe the medication from our clinics. We don't rely on other clinicians to do that. And this flow sheet just kind of summarizes our approach, where we find our patients with case finding at the hospital or outpatient consults, and then move them through the program to get them access to their care. And that kind of mirrors our approach we'll see for BHO in a little bit. And we have, many detailed guidelines to help us decide what treatment is the best first-line option for our patients with osteoporosis after fracture, particularly those that are at high risk. Some things that might increase their risk besides just low bone density would be advanced age, frailty, steroid use, or increased falls risk. And in those patients, we're using injectable or infusion type treatments as first line often. So then when we consider, well, then what do we do and what guidelines do we have for our BHO patients? There's not quite as much expert consensus out there. A lot of it at this point is opinion because we don't have a large body of research to support it quite yet, but it's certainly coming with time. So this is our current approach at our institution. So if a patient is considering scheduling elective spine surgery or joint replacement, again, for our case finding, we're looking at adults over the age of 50, particularly if they've had a fracture, if they're known to have low bone mass or osteoporosis and are not currently treated, if they appear to have low bone mass on their x-rays, which everyone has an x-ray before they see our surgeons, of course. And then we also do some case finding with FRAX risk score prior to obtaining bone mineral density. And if that score is above 10%, we're using that to, justify getting some additional information because they may be at risk. So when we've gone through this list here, all the answers are no. They certainly just go straight to scheduling their surgery. But if the answer is yes, we need more investigation, then we're looking at, stratifying patients if they're low, high, or very high risk to determine how much treatment and, when should that occur before surgery or if it can happen along with it. So when we're looking at, who might be low risk, those are our patients with normal bone density, and they typically just proceed to surgery, though making sure we optimize calcium and vitamin D. If it's low bone mass without other risk factors, again, if their FRAX score is low, we're probably just going to proceed to surgery without any sort of prescription. But then when we get to the lower T scores and possible higher FRAX risk, we might consider an anti-resorptive, but still proceed to surgery. And then if their case is more severe because they've had fractures or very low bone density, we may be looking at bone building treatments and then delaying surgery potentially to try to optimize things further. And just to kind of further tease out, what these categories look like with bone health optimization, because it's a little bit different. Again, we're going to call the patient normal if their FRAX without bone density is less than 10%. They've not had a fracture above the age of 50. And if they do have a bone mineral density, obviously we'll still calculate that FRAX score. But if there's no prior fractures, normal trabecular bone score and Hounsfield units when available, those cases are not needing treatment. When we're looking at folks that do have that T-score between -1.1 and -2.4, they have not had prior fracture and still have a low FRAX risk. Again, we're going to proceed. They might be at slightly higher risk, but certainly not into those treatment categories quite yet. When we get to those osteoporotic T-scores and a higher FRAX score risk for that major osteoporosis fracture between 20 and 30%, then again, we might be considering treatment. With more severe cases, such as those that have had a recent fracture or multiple previous fractures, higher FRAX score perhaps greater than 30% or very low T-score less than -3.5, that might kind of look at, classifying them at higher risk when we're thinking about surgery. And again, this is really mostly expert opinion at this point, not a lot of robust data sets to support that. So we're trying to at least start somewhere to try to, help move things forward. And when we're looking at, these risk categories, things that might cause you to take pause and maybe think about higher risk versus lower risk when you're facing surgery would be if you do have that opportunistic CT with low Hounsfield units, that low trabecular bone score, such as below 1.23, history of frequent falls, another big one, particularly when you're repairing or doing surgery because you don't want that to fail because of a fall. And also, we want to consider the type of surgery. Is it a multi-level fusion? Is it a revision arthroplasty because of loosening or failure of previous components? That certainly would be higher risk. So in thinking about trabecular bone score, this is looking at microarchitecture in a surrogate way. So the upper panel is a normal trabecular bone score, whereas the lower panel is that low trabecular bone score with, lots of gaps and holes in that structure. So that's going to be concerning for hardware and healing. And then thinking about what opportunistic CT looks like, this is one of my spine patients, and she had a CT to look at her listhesis in detail. So we measured the Hounsfield units on that, and it was less than 100. So she, definitely needed that bone mineral density prior to proceeding with surgery, and her spine T-score was a negative 3.2. So she started on anabolic therapy. So this was very helpful in her case to have some, information to look at ahead of time. And again, when we're looking at this optimization piece, we're thinking about, who may need to consider a potential delay in their surgery, but still always balancing, the patient need. Obviously, if there's neurologic issues or deficits, you're not going to delay surgery. But if it's truly elective, optimizing bone health, certainly, we hope will help to prevent poor outcomes. So when we think about classifying our patients, we consider kind of a lower risk surgery, a laminectomy, a cemented replacement. And if it's more that low bone mass category, we do need treatment still, maybe 3 months, but for a, 1 or 2 level fusion, uncemented joint replacement, or, T-score osteoporosis, possibly a little bit longer, 3 to 6 months. But when you're looking at, really these spinal corrective multiple level surgeries, revision joints that have already failed, or, the more severe modifiers we talked about earlier, maybe even a little bit longer. And in those more severe cases, we're using more of the bone building medications to help speed that process along. So when we started our program, it really was exclusively fracture patients we were case finding, and the bone health optimization just really kind of grew organically. Surgeons recognizing, risk factors in their patients once we started talking about osteoporosis with our FLS patients. And really the major difference, I think, is, the urgency. If someone is needing surgery, you'll want to do their bone health assessment as soon as possible and not have that delayed 5 or 6 months. If that's your normal wait time, that's not going to work. So really, adding these patients into that FLS program can really be very seamless, if you do have access for them. And I think really, the thing that we talk about the most with our bone health optimization program is really looking at, really collecting as much data as we can and using supporting information to try to tease out who may have lower bone quality or who may be more at risk because of their, history or other personal factors or accessory information. And advanced practice providers, certainly are well suited to, transition from one program to the other, or potentially, run both simultaneously, because you're looking at the same disease in an adult population. So just as kind of a quick summary, again, with your FLS, you may be doing inpatient or outpatient. With bone health optimization is, typically outpatient. We get a few consults if there's a fracture during surgery, but those seem to be lower in number than the outpatient consults. But looking at the same population, adults over 50, the steps that we take is, looking at bone mineral density if indicated, getting that lab work up, nutrition counseling, falls prevention. We prescribe the medications and follow the patients. And then the follow-up just really depends on the treatment that was chosen. So that's what I had prepared for now.
Thank you, Kristyn. Perfect. Excellent. As usual. Can we take some questions, and you can unmute yourself and speak, or if you're shy, you can use a chat. Kristyn, I had a question for you. Are there certain orthopedic programs that you think would be best suited for a BHO program, or is it across the board? Say I'm an orthopedic surgeon, most of what I do is total knees or total hips. I really need it just as much as a lumbar fusion orthopedic surgeon does.
I mean, I think low bone density is so common, particularly with our aging population, that it really should be looked at across the board. We've done several kind of pilot studies looking at different orthopedic locations on the body, whether it be, needing a shoulder replacement, a knee replacement, a hip replacement, a spinal fusion, a distal radius fracture. And, we seem to always find that half of our patients have low bone density and should be evaluated, regardless of what the actual underlying orthopedic problem was. And honestly, I just think that's a reflection of the fact that it's a common disease and we don't do an amazing job, generally in the United States of case finding these folks for prevention to start with. So having them as a captive audience in the orthopedic clinic when you're, going to be touching the bone makes sense to look at it for most everybody.
Perfect. And I've got a question for Dr. Anderson. How important is it for these programs to be within an orthopedic department?
I mean, I think it depends on how your health system is set up. Certainly there are some other departments that work very cooperatively together. There's other health systems where folks are more in silos, and there isn't as much cooperation between different departments. So it's really just kind of, I think, doing an assessment of the key players at your institution and seeing where are they located, who are the folks interested in bone health. We have some primary care clinicians that are very interested in bone health, and we hand them a 5-year program and they take it and they run with it, and others are like, I'm not going to touch that with a 10-foot pole. So I think it's really just kind of doing a survey or like seeking out those folks who you've noticed have an interest in it and banding together and having a group that can help support each other. Being in orthopedics, it's easy because they can find me, and we do lots of curbside consults and a lot of in-basket and other, quick messaging because we're in the same department. But I've talked to other clinicians who are in different departments and they still, have a good rapport and they have a good system of, getting the patients to where they need to go.
Got 2 questions from Allison. The first one, there are some concerns from our orthopedic surgeons about delaying surgery. How do we address the concern? And the second question is, what about getting insurance coverage for the pre-op medications?
So, I mean, obviously delaying surgery is always a big deal because surgeons always want to keep those schedules full. So, it's certainly a case-by-case situation. Some patients have designed their whole life around a surgery being on a certain day and they can't change it. And, you just take the hand of cards you were dealt and do the best that you can with the time you have. But, I think a lot of folks are very reasonable. And when they're facing a big surgery, they want to give it every possible chance of success. And they do not want to go into that operating room again if they can help it. So if it's truly elective, I think the patients themselves, a lot of times are like, well, yeah, now that we've, discovered this, I want to optimize this as much as I can, even if it means I have to wait a couple more months. But there's others that, they're going to proceed either way. And you just, do the best you can with the time that you have. And maybe they go to surgery tomorrow like they were going to, even if they have osteoporosis. And, there's certainly techniques and, surgical instruments and tools that can be used in a setting of osteoporosis if need be, because emergencies happen. But, we just try to take a really logical approach. And when it truly is elective, give it some time. But if it's more urgent, then, you just move forward. As far as insurance coverage, I mean, I write a lot of letters. Definitely look for that supporting data. And there is lots of literature about, low CT Hounsfield units correlating with low bone density, even if you don't have a terrible T-score, maybe, because it's, causing interference from your osteoarthritis, which is why you're having surgery in the first place. So we use those papers and, submit those with our request for authorization for medications. And if someone doesn't have osteoporosis, we're not going to treat them with anabolics unless there is, some really, big risk factor that's there that, puts them into that clinical osteoporosis category. But we have had some success with the supporting data with the trabecular bone score and the CT Hounsfield units, using those as surrogate markers for poor bone quality in our letters.
Paul.
Yeah, I would just follow up on the question about surgeon delay. The surgeon with the patient has to really analyze this in a cost-benefit analysis. I'm a spine surgeon, so if a patient has major neurologic deficit, I'm not going to wait to do surgery. We'll deal with the osteoporosis post-op, and we obviously are taking a risk, but it's a reasonable risk. The same would be true for an arthroplasty surgeon. If you have a patient who has a collapsed femoral head and absolutely cannot walk, it makes no sense to keep them on bed rest, literally bed rest for 3 months, losing bone while you're trying to build it up. So it's something that has to be individualized. Frankly, the patients who can delay their surgery usually are very satisfied that this is getting attention to. And I haven't seen a lot of pushback as long as the physician, as well as in my case, Kristyn, spends the time to explain the rationale. And if you look at revision surgery rates for total hip, total knee arthroplasty, they're at least double in the osteoporotic patients. And the revision spine surgery for lumbar fusions is 40–50% in osteoporotic patients. So you explain those numbers to patients so they kind of get it.
Thanks, Paul. All right, any other questions? Excellent discussion, excellent talk as usual. Okay,